In 1835, British naturalist Charles Darwin described how people were bitten by the vinchuca, a South American insect. 1 year later, Darwin returned to England and fell ill. Doctors were never able to diagnose the cause of the illness that would incapacitate him until the end of his life, but it is now largely suspected that he had Chagas disease. It is said that this tropical disease has existed in the New World since ancient times. Pre-Columbian mummies dating back 9,000 years show signs of the infection. In 1909, a Brazilian physician, Carlos Chagas, discovered the illness and gave it his name. Some years earlier, the cause and vector of human African trypanosomiasis, a close relative of Chagas disease, better known as sleeping sickness, had been discovered. Carlos Chagas made his discovery almost by chance. He was sent to a region decimated by malaria, and he noticed an unusual swelling in one of his patients. He discovered a parasite in her blood he named Trypanosoma cruzi, a trypanosoma different to the ones that were already known. Chagas accomplished the remarkable feat of describing the disease from A to Z, not just the parasite, but also its vector, the vinchuca bug, and its clinical signs. But many countries refused to invest in the study of another new disease and tried to lull people into believing it was a hoax. It was only in the 1930s that the existence of Chagas disease was recognized and accepted. And it took until the 1950s for it to become acknowledged as a public health issue. At the time, out of the 18 million people infected, 250,000 died every year, most of them in South America. Since the discovery of Chagas disease, the search for a cure has been a major challenge. The principal drug, benznidazole, dates back to 1969. Despite its numerous side effects, benznidazole and nifurtimox, another equally toxic molecule, are still the only drugs available to treat the disease. Seven to 8 million people across the world are infected with the parasite that causes Chagas disease, which kills over 12,000 people a year. The vast majority of patients are in Latin America, as Chagas disease is endemic in 21 South and Central American countries. As 60% of patients are symptom-free for several years, the available statistics are still far from reality. Chagas disease is one of the neglected tropical diseases which almost always afflicts the poorest on the planet. Bolivia, where the bug that transmits the parasite to humans originated, is one of the poorest countries in South America. With 15% of its population infected in 2010, and despite the program launched to combat the disease in 2003, it is still the worst affected country. Regional initiatives, particularly insect eradication, have halved the number of cases over the past 20 years, and divided by 10 the risk of contracting the disease. Transmission of the parasite by the vinchuca has been halted in Brazil, in Chile, in Central and West Bolivia, in Guatemala, Honduras, El Salvador, Nicaragua, and Belize. But Chagas disease continues to invade new territories. Benefiting from deforestation, it has now made an appearance in Amazonia, which up to now had been spared. In the Amazonian forest, the vinchuca is safe from insect eradication campaigns. The disease has also taken advantage of South American population migrations to spread to other lands. In 2010, more than 500,000 cases were recorded in the United States, and almost 100,000 in Europe, with roughly half of those in Spain. In South America, the cost of treatment is the primary obstacle to combating the disease. In Colombia alone, in 2008, The annual cost of treatment was estimated to be more than 230 million euros, and the cost of insecticide spraying to eradicate the bug was 4.5 million. Chagas disease is caused by a highly mobile, microscopic parasite called Trypanosoma cruzi, or trypanosome. The parasite is transmitted by a vector called the triatamine bug, nicknamed vinchuca in Latin America. The bug hides between stones in the walls of houses and under straw roofs. During the night, the vinchuca comes out of hiding to feed on human blood. When it's finished feeding, it defecates next to the bite. The victim later scratches the bite, unwittingly helping the parasite to enter the body. The parasite that causes Chagas disease transforms throughout its life cycle. The parasite penetrates the tissue cells and multiplies before entering the bloodstream. Once in the bloodstream, it infects even more cells. This is the first, acute phase, which lasts about 2 months. Due to the large number of parasites in the blood during this phase, it is the only time the disease can be diagnosed. People may not even know that they are ill as symptoms are so mild. A slight fever, headache, pallor, and muscular discomfort. Chagas disease does have some very recognizable signs, but they're rare. A skin lesion around the bite, or swelling of the eyelid, called Romagn's sign. Then, nothing at all. This is the chronic, asymptomatic phase, and for years or even decades, infected people have no apparent symptoms. The disease deserves its nickname, silent killer. 10 to 30 years later, a third of sufferers develop the chronic phase. It can be rapid, and some people die without ever knowing they had the disease. During all these years, the parasites have been present in several of the body's organs. In the digestive system, they cause the colon and esophagus to dilate. In the nervous system, they can cause dementia. In the heart, it can lead to cardiac disorders, some of them fatal. Three strategies are used to combat Chagas disease: controlling the insect, screening, and treating the disease. As there's no vaccine against Chagas disease, the most effective way to prevent Chagas is to kill the vinchuca, the bug that carries the disease, by spraying insecticides. In addition, other preventive measures, such as bed nets, are used. As vinchuca can soil food, good hygiene in the preparation and storage of food is also necessary. Despite the indisputable achievements after decades of insecticide use, the disease is still present and continues to spread. A blood test shows if there are antibodies that have developed due to the presence of the parasite. However, a laboratory and trained staff are necessary to carry out the test, and both are rare in rural regions where the disease is most common. Alternatively, doctors can use a rapid diagnostic test that, in a few minutes, shows if someone has been infected or not. But in this case, the result still has to be confirmed with a blood test. Once the diagnosis is made, the patient is given an anti-parasitic treatment. If the patient has heart problems, they may need a pacemaker or even a transplant.
You know you carry the Chagas parasite in your body. What we're looking at now is your heart, whether it's been affected by the parasite. So you have the parasite, but it hasn't yet caused any damage. That's what's important.
Oh, that's good news.
So feeling reassured?
Oh, yes.
Currently, doctors usually treat patients with benznidazole or nifurtimox. But both of these already outdated treatments frequently cause multiple side effects. Neither of these drugs is fully effective unless the patient is treated during the first, acute phase of the disease, when patients don't yet show any symptoms. This highlights the importance of screening. It's hoped that new, more effective, more practical, and shorter treatments will be available in the next few years.
Chagas disease is undoubtedly a neglected disease. It's estimated to affect nearly 8 million people in the world. Barely 15% of patients are diagnosed and treated. But in reality, we think the number of people infected is significantly underestimated. If so few people are treated, in our opinion, it's because there are only 2 drugs to treat this disease, nifurtimox and benznidazole. Currently, treatment is very long, too long. Patients frequently lose hope and give up. A number of organizations, including DNDi, have identified new drugs, other than nifurtimox and benznidazole, to treat Chagas disease. These drugs use lower doses and a much shorter treatment. When they become available, these new drugs will be easier to administer to many more people. We have now completed the studies on some potential new treatments. The results of the clinical trials were very promising, leading to studies of new treatment protocols. One of the drugs we tested, E1224, didn't give the hoped-for results. It was less effective than we had expected. So we decided to redirect our research, and we're going to combine E1224 with benznidazole. We think that this will improve the efficacy of treatment and also reduce the toxic side effects, making it easier for patients to tolerate. We are hoping that new treatments will be available for patients by 2018.